So warm welcome. I, as usual, hand it over to the moderator for moderating the session of the day. And warm welcome to Dr. Preeti.
Thank
Thank you,
you.
Dr. Preeti, for being our guest speaker for the day.
Thank you.
And
Thank you so much.
yeah,
So, good evening, everyone. I want to extend a warm welcome to everybody who has joined already. This is for the Flavor of the Month CME webinar series that we hold every month. As we all know, today's topic is how to approach and manage Epiphora. Epiphora watering eye basically is an extremely common complaint. Every other patient who walks into the clinic will have a watering eye complaint. So, it's of interest to all ophthalmologists, not just oculoplasty surgeons, right? It's my pleasure to introduce our speaker for tonight, Dr. Preeti Udhay. She's very well renowned, fellowship trained from the esteemed Shankar Nitralaya and multiple other places. She has over 20 years of experience in the field now, and she's currently heading oculoplastics for Dr. Agarwal's eye hospitals. Besides, she's also the managing director and head of plasty at DRR Eye Care and Oculoplasty Hospital based in Chennai. She's also the global examiner for FRCS and Asia Pacific faculty for AOCMF, which is basically a trauma based organization based out of Davos. She has trained several fellows and postgraduate students under her till now, and her special interests are facial aesthetics and also complex orbital and orbital surgeries, especially related to orbital trauma and including virtual planning and navigation based surgery. So I'll, without wasting any further time, I would give it over to Dr. Preeti Udhay.
Good
Ma'am,
evening,
please come.
and thank you. Thank you so much, Deepika, for that introduction. And
Thank you.
thanks for inviting me over to spend this evening with all of you. So the topic, as she said, is very, very common. Epiphora, I think it constitutes about 30 to 40% of our clinic cases. Both the general ophthalmologist as well as oculoplastic surgeons see this very often in the clinic. So I have tried to make it a little easier for you to diagnose as well as treat this condition through this presentation. So the most easy way to remember to treat epiphora is you have to find out whether there is increased secretion or it is some surface issue or it is a problem with the drainage. Now, drainage, I mean not only this anatomical drainage system, but also functional drainage system, which includes the lacrimal pump. So you know that some part of the pretarsal orbicularis that encircles around the common canaliculus, and some part of the preseptal orbicularis wraps around the lacrimal sac, and that helps in the lacrimal pump. And when this pump gets affected, especially in trauma cases, you will have very scarred orbicularis in this area in the trauma patients, and you will find the pump is not functioning, and that can be a cause of epiphora. Now, just to quickly go through the anatomy, we have learned that there is this punctum, and then you have the vertical portion of the canaliculus, the horizontal portion, the common canaliculus, the sac, and the nasolacrimal duct, which opens into the inferior meatus. Now, remember that normal system drains into the inferior meatus, but when we are doing a DCR, we are opening the sac into the middle meatus. Okay, so that is why when we are intubating the system, whenever you're doing a primary intubation without a DCR, it is more difficult because this NLD is in the posterior part of the inferior meatus. So you have to go all the way posterior to see the valve of Hasner and the opening, the lower opening. Sometimes you're not able to do that and you will have to lift the turbinate to see that probe. Whereas in a DCR, since you're doing it in the middle turbinate, it is very easy. You can see it very clearly. Okay, now all this anatomy we have learned through years, but now we have electron microscopy, and you see this beautiful study done by Javed et al. I have taken these pictures from his presentation and his papers, and here you can see actually how the canaliculus looks like in the cadaver as well as electron microscopy. So you see this, that this canaliculus is not like a straight line, okay? It has got these waves, it is undulations are there. So many a times I see that the patients are referred from other branches to us saying that there is a block. The patient travels so many kilometers to see us. When we do syringing, it's patent. Now, why does that happen? That is because you don't stretch the eyelid enough. Only when you stretch the eyelid, these undulations will get straightened and your cannula will reach correctly for you to get the correct diagnosis. Okay. Also, what we have learned, vertical and horizontal portion, it may not be true. Now, like in this cadaver dissection, you can see that there is no vertical and horizontal. It is just going like a curve up to the punctum. And this in the electron microscopy, you can see this lower image, you can see that it is a curve. So whatever we have learned in the past, now we have much better understanding of the anatomy. But for exams, please follow what has been taught before. But you need to know the current studies. Now here you can see the electron microscopy beautifully. This is the, can you see my cursor on the screen? This epithelium, you can see this columnar epithelium, and all these are the Horner's muscle, the muscle which surrounding this epithelium. And this is the histopathology picture. So many a time students ask me that when there is a common canalicular block, how do you get regurgitation to the opposite punctum? That is because common canaliculus is not like a small area. You see this large area here. So if there is a block here, you still have this passage for the water to go. Okay. And after the common canaliculus, you have the sinus of Mayer, which is like a depression, and then comes the sac. Okay. So that is the correct anatomy. Also, you have the valve of Rosenmuller. So many a times when you're doing a probing or a syringing, you're hitting against that valve of Rosenmuller, and then you feel that it is a common canalicular block, but the system is patent. This happens even on table when you're trying to do a probing. The probe doesn't go correctly because that patient may have a very prominent mucosal fold. So these are all the studies that have been done recently through electron microscopy, and it has given us a better insight. You also see, like in this trauma patient, I have put two mini monocas, and you can see the beautiful anatomy when the canaliculus is cut. The canalicular epithelium is paler. It is white in color compared to the sac, which is more pink. So you can easily see that epithelium because of the color difference. And that is the calamari sign that we say when you have a canalicular cut, you can see that white ring, and that is the calamari ring. Now, when you see a patient with Epiphora, it is important to ask them when the symptoms started, because you may have a 3-year-old child who comes to the clinic and the mother says the child is watering. Now, you cannot assume that the child has watering since birth. Okay, many a times, many children start getting watering after 2 years of age or 3 years of age. At that time, you must think of secondary causes like an enlarged adenoid, or the patient has recurrent rhinitis. Since the NLD opens into the nasal mucosa, whenever you have inflammation or swelling or rhinitis in the nasal mucosa, they will have an obstruction and they will have this kind of symptoms of NLD block. So, when started is important. Second thing is, even if a child comes at 3 years of age and the mother says that the watering is since birth, I would still go ahead and do a probing instead of doing a DCR. So even in older children, when the etiology is from childhood, I would still try to do a probing. But I also inform the parents that since the child is older now, the success rate may be lower. And if on table I find a bony block, I'm going to do a DCR. So I prepare the patient for both. So much importance for you to understand when it started. Also, seasonal patterns. Many a times patients say, when I'm traveling, I get watering. That is because of change in environment. They are allergic, the nasal mucosa gets congested, and that's how they have watering. So it's typical history of allergy. Also, the discharge, what kind of discharge, sometimes if they have dry eye, you will have the mucoid kind of discharge. If they have NLDO, you will have profuse discharge. Whereas if there is conjunctival inflammation, the discharge is different. So the kind of discharge is also very, very important. Of course, history of trauma. Many a times patients come to you for DCR, they forgot some kind of injury in the past. So you need to ask them always whether there has been any trauma. It can manifest many years after trauma also. Also, previous surgeries, they may find it irrelevant for them to tell us if there is any nasal surgery, if there is any sinus surgery, thinking that it's not related. So you need to specifically ask them, is there any sinus surgery? So very often we have seen that after sinus surgery, after FES surgery, the ENT surgeon eats off the NLD also. We have seen with the debrider, everything gets eaten off. So many a times patients come with NLD after a sinus surgery. Also, systemic diseases and medications. Many anti-glaucoma medications, many systemic chemotherapy drugs cause a punctal stenosis, cause canalicular stenosis, and that history helps us to find out the etiology. Also, certain like medications like 5-FU also cause a lot of stenosis. Now, this tear film height, I feel many people don't see it very regularly, but I feel it's a very important sign because in a child, nothing else you can examine. You can see the tear film height in a child, and that really tells you. Many times patients come and say, I am profusely watering, but you look at them, you talk to them for 10 minutes in the clinic, tear film height is okay. They are not really that much watering. They must be watering intermittently then. So this is a very important sign. You can just see the tear meniscus height just by inspection, or you can add a little fluorescein and see that line just above the lid margin. And that also tells you the fluorescein dye disappearance that I'm going to come to later. Then after the tear film height, look at the punctum. Punctum, you can see agenesis. Nowadays, we don't call it atresia. We say agenesis. When you don't see any signs of punctum, it is agenesis, or there can be dysgenesis of the canaliculus or agenesis of the canaliculus. Now, recent studies have again shown us that whenever there is punctal agenesis, when you don't see any punctum from childhood, there is always associated canalicular agenesis. So the earlier teaching that, try to do a canalicular cut down, try to come retrograde from the sac and try to open the canaliculus does not work. Usually punctal agenesis is coexistent with a canalicular agenesis. You can sometimes have duplication of the punctum. Now, do you really treat them? No, many patients with double punctum do not have watering. They have symptoms of watering if they have other blocks like NLD. Very, very often, if you have two puncta, they can have block lower down, which is the cause of watering and not the punctum. So what you need to do is do a syringing and evaluate the system. Usually when there are two puncta, the proximal punctum will not be functioning much, but the distal punctum, when you syringe through that punctum, you will find the block or a patent lacrimal system. Also, stenosis of the punctum and obstruction you need to check. Look for inflammation of the punctum. Now, as oculoplastic surgeons, it is like glaring into you when you see a canaliculitis or punctal inflammation. But very often it gets missed by general ophthalmologists because they don't look at the punctum that carefully. And that is a very common cause of epiphora. Now, inflammation, you can have either idiopathic inflammation, which we call ICID, or it can be canaliculitis per se, which is infectious. And there can be punctal malpositioning, okay, like facial palsy patients, they have punctal ectropion, and that can cause watering. So this is the paper that I was talking about where they have proven that punctal agenesis is always associated with canalicular agenesis. And this is canalicular dysgenesis. That is, normally when you're doing a probing, you can't see the probe, okay? If you're able to see the probe, that means there is canalicular dysgenesis. That means there is hypoplasia of the canalicular wall. And you have to be very careful in probing in these patients because you can actually break that membrane and cause a scarring of the canaliculus in these patients. So this is a common problem. We have seen many a times the probe being seen when you're doing a probing. Also, this is the paper. You can take down all these references. They are very good papers to read. Now, this is another syndrome. We have seen this whenever there is. So now this kind of a patient, you have a very prominent nasal bridge. In these patients, the medial canthal tendon is very anteriorly placed. So the punctum is not touching the eyeball. It is not opposed to the ocular surface, and that can lead to watering. And the treatment for this is bring the medial canthal tendon posteriorly. Because it is anterior, it is pulling the lid with it forward, and the punctum is not able to oppose against the groove. Now, very common quiz question is, why is it called centurion? That is because you see these centurions, these Roman centurions have a nose like that. So this is a typical look of a centurion, and that's why it's called a centurion syndrome. Now, ICID is a very common problem. We have not described it earlier, but now it's very common. Just like idiopathic orbital inflammation, we have idiopathic canalicular inflammatory disease. It is non-infectious and it has 5 stages. I will not go into the detail, but I think everybody as postgraduate should know that there is an entity called ICID, which is actually canalicular inflammation. The vertical portion of the canalicular epithelium comes up and is seen through the punctum. You will have some kind of congestion, dilated vessels near the punctum showing inflammation. And they have found T cells in this kind of inflammation, and therefore cyclosporin works for this. So many a times you have this kind of punctal inflammation and you don't know what to do. Cyclosporin works for these patients. Now, after the punctum, you come to eyelids. Okay, eyelids, you look at the margin, blepharitis, mebomonitis. It's the commonest cause in cataract patients. You see all these patients after cataract, they are referred to oculoplasty for watering. That is because the patients don't clean the eyelid margin at all because they are scared that the lens will get dislocated. They've not had a bath maybe or washed that area very well. And this blepharitis and mebomonitis is a common problem of epiphora. Also, dynamics of lid closure is important. Whenever you close the eye, the lid margins should oppose each other. Sometimes there is an override because of lid laxity. The punctum is not well opposed to the globe, and in that case, you need to treat the eyelid. Also, malpositions like epiblepharon, entropions, and centurion syndrome, which I described. Now, this lacrimal fistula is a very common problem that we see in our regular practice. Remember that water will always go through the path of least resistance. So, this fistula will not drain fluid if the pathway below is patent. Most of the time, this fistula is associated with NLD block. And because of that block, the fluid is now coming through the fistula. Whenever you do a DCR, that fistula also many a times closes. But what I prefer to do is follow this fistula completely. Like you put a probe inside, you see the dissection. I've dissected all around and remove the whole fistulous tract along with a DCR. And that settles your fistula along with the NLD block. Now, this is how canaliculitis looks like. You can see when you press with two buds, I take two buds and press from either side, and milking out the secretion itself cures the canaliculitis many ways. But you need to milk it out very regularly, many times, maybe about 10 or 12 sittings till you don't have any secretion. And I flush it with antibiotic, okay? So you can see the secretions keep coming out, and it is actinomyces most commonly even in India, though many papers have reported as staph being common because we didn't have enough media for actinomyces diagnosis. Actinomyces still remains the commonest cause. So this is how it has to be milked out. Most of the time, even in this kind of canaliculitis, the canaliculus is patent. Canaliculitis affects the wall of the canaliculus. It does not cause a block. So most of the time you are able to syringe these patients, give them antibiotics and milk it regularly, and that cures it. We don't advise canalicular cut downs nowadays, which we used to do earlier. If we need to drain out all these secretions, they are not getting milked out adequately, you can use this kind of a curette. That is the Calazion curette that we used to use. You use that, go inside and curette out all the secretions. But don't do a cut down. Only if it is very recalcitrant, you're not able to treat it, then you do a cut down. So now we try to preserve the punctum, preserve the canalicular system without any punctoplasty, no snip procedures, no cut downs. All those are avoided. This was one of the papers that I had written in 2008 on how to treat this canaliculitis. You can read this reference. Now also eyelashes, trichiasis, dystrichiasis, common causes of watering. Many a times you may find this a very simple cause, but on slit lamp you're not able to see those very fine light color hair which you see in Steven Johnson syndrome. So and the patients are very photophobic, they don't show you very well. So you miss this. You need to really look for those light colored ones, okay, not the really dark ones, which cause the watering in these patients. Look at the conjunctiva. Many a times when the patients are old, they have these folds of conjunctiva which are blocking mechanically the punctum. That is conjunctivochalesis. And to treat that, what we do is we make multiple spots of radiofrequency, which shrinks the conjunctiva. I don't like to chop it off like many people do. You can just shrink that conjunctiva, and that will come away from the punctum and improve the watering. Also, cornea. I think the common cause of unilateral watering, sudden watering, is foreign body. So conjunctiva, cornea, evert the eyelid and see every patient with epiphora. Okay. Now, RHO+. RHO+ is a very common sign, but many a times people find RHO+ negative, but when we do it, it is positive. Why is that so? That is because you are not going deep enough to press, because the sac is posterior to the anterior lacrimal crest. You need to actually go inside. See the way this is being done. You have to go inside and then press on the sac. You will get a positive response. Now, whenever the RHO+ is positive, that means it is nasolacrimal duct obstruction, because only the sac secretions can be so thick and so mucoid. So mucoid secretion means it is a NLT block. And then you can confirm it by probing this. You pass the probe straight. So whenever you're doing a probing or syringing, you stretch the eyelid nicely, pass the probe so that the probe is parallel to the lid margin. And then you do the syringing or the probing so that you don't have problems with the false positive sign. And whenever there's an NLD block, of course, DCR is the treatment. Whenever there is a watery discharge, there is no discharge, there is just watering up for the patient, and there is a clear regurgitation, then it is either a common canalicular block or a canalicular block. So whenever you're doing a probing here, you will have a soft stop. You're going to touch the medial wall of the sac. You're not able to go in and touch the lateral wall of the sac. You're not able to go in and touch the medial wall of the sac like this, and that indicates it's a common canalicular block. So just to clarify the various terms in syringing, I think this is a very common problem with all the PGs. Now, whenever you have a clear regurgitation from the opposite punctum, means you're syringing from here, it's coming out from here, that means it is a common canalicular block, okay? But it can also be that the patient has a very, very shrunken and fibrosed sac. In that case, also the watering, there can be regurgitation, especially if you're forcing in with a lot of force, there will be regurgitation. That's why we advise syringing with a 1 cc syringe sometimes, so that you cannot put too much of force, otherwise you'll always get a regurgitation. To distinguish between these two, you do a probing and see. If you have a hard stop, it is a small fibrous sac. If you have a soft stop, it is a CCB. So always do a syringing. If you have a clear fluid, do a probing and see if you have a soft stop. Now, when you have a clear rigors through the same punctum, it is a canalicular block. When you have a canalicular block, you should know whether it's proximal or distal. Because if it's a block which is more than 8 millimeter from the punctum, that is, if it's a distal block, then you can do a trephination. Okay, so you need to know where the block is. Now, fluorescein dye disappearance test is an important test to know the functional patency. Okay, so what I do is I tell the staff to put fluorescein and allow the patient to just sit for 5 minutes. They can normally blink. After 5 minutes, they come inside. I put them on the slit lamp, put the blue filter, and see. You should not see any dye left behind after 5 minutes. If the dye is still there, that means there is a delayed disappearance. That means there is a functional block. If you do a syringing, it's patent, and if the dye is still there, that means it's a functional block. Now, the next test is CT-DCG. When do you do a CT-DCG? Not in all patients. You do it only if there is trauma or if there is malignancy. If something is suspicious, you're doing some syringing and you're not very sure, then you can do a dye test. Now, what do we do in dye test? We take lipoidal, that is iodine-containing contrast. We mix it equally with saline and put as a drop. And then that drop goes into the lacrimal drainage system, and then you do a CT scan. So it is a functional, you're not syringing, you're actually putting a drop. Most of the time, we are able to do a good DCG that way. Only sometimes they need to cannulate and then put in the contrast. So now you look at this DCG, you can see the sac on either side. This side, the sac is a little bit enlarged. You can see upper and lower canaliculus beautifully. This is the CT scan which shows you that this is the enlarged sac here. Now, this is a trauma patient. You can see where the plate is. So suppose the plate is near the lacrimal sac area. You can be prepared with a plating system so that you can remove the screw. You need a specific screwdriver so you can see what kind of screw is there on the CT scan. It's important to be prepared. So in trauma patients, sometimes the bone is sclerosed. You're not able to go in with a punch. You will need a drill then. You will need some chisel and hammer then. So all that you can be prepared by doing a CT-DCG. So this was a paper that I had written about CT-DCG again in 2008 or something. 2008. You can read this as a reference for CT-DCG. Now, whenever we are doing the sagittal cuts for CT-DCG, it has to be oblique sagittal because NLD direction is downwards, lateral, and posterior. It's not in one straight line. So when you just do a sagittal, you will not be able to see it. So only a very experienced radiologist who can do an oblique sagittal, you will be able to see the entire NLD like this. You can see this NLD. There is a dye in the NLD here. This is the coronal section with the NLD, and here there is a dye here, and there is no dye here. This is the sac, and you can see the contrast in the NLD. So I hope you can understand how to read this CT-DCG. You can also have a 3D CT-DCG. Just make a 3D reconstruction and you can get the whole system there. Now, this is one case. Let's do some cases. I think if I keep on talking, it's going to be boring. So this is a newborn child. Comes to you with this kind of a swelling. The eye is quiet, cornea is clear. He has watery discharge. What are you going to do for this patient? This skin just looks red here because the child has got that delicate kind of skin. See the other eyelid also, it's also red. But when you touch, there's no tenderness there. The child doesn't cry. So this is a mucocele, okay? So for a mucocele, first treatment is massage, okay? Massage these patients. Most of the time, all the mucus will come out and you continue massaging and you can maybe solve the problem. If massaging fails or if the child gets recurrent infections, only then go ahead and do a probing. Otherwise, in this kind of an enlarged sac, you may have a false passage if you just go ahead and do a probing. Now, if you have this bluish kind of discoloration in an infant, it is an amniotocele. Okay, that is because the amniotic fluid has gone in, but the problem is the same. It's a membrane at the valve of Hasner. So again, something like an NLD only. So again, the treatment is massage, and if it doesn't subside, then only probing. Avoid probing whenever there is an acute dacrocystitis. Many a times, whenever children come with acute inflammation, you get very tempted to do the probing because they are very much worried. They want the solution to happen fast, but no, you will have a very high chances of false passage if you're going to do probing in acute dacrocystitis. Just give them local compresses, antibiotics, anti-inflammatories, wait, and then start the massage as soon as that acute episode subsides. Now, in children, the septum, everything is very, very lax, and therefore chances of having preseptal cellulitis, orbital involvement is higher. Lacrimal abscess, corneal ulcers are common, and also endophthalmitis if intraocular surgery is done. So therefore, you need to treat this quite seriously. If there is an abscess, how do you know there is an abscess? There will be fluctuation, common, just like an abscess anywhere in the body. If there's an abscess, you do an IND. Otherwise, massage. Now, how do you massage? You ask the mother to take some eye ointment in their finger for lubrication, press in the sac area, and then come down. Okay, this 40 strokes every day. So 10 in the morning, 10 in the afternoon, evening, and night. I show the whole thing on the mother's face so that she knows how much of pressure to apply. Okay, if you do it on yourself, they will just do like this because they are scared to even put pressure on a small baby, and that's not going to help. The logic is a sudden hydrostatic pressure over the sac area may burst through a persistent fetal membrane, and we have seen that it works very well. Now, the next option, if the probing and if the massage fails, is probing and syringing. And if that fails, you do a silicone intubation. And if that fails, you do either a balloon or a DCR. So this is how it has to be done. Probing, I'm showing you. First, I'm doing the Roplas in the normal eye. The right eye is the one which is involved. Do the Roplas so that whatever secretion is there, you remove it out so that the false passage chances are less. Then I'm doing syringing first in the normal eye. Okay, so that you don't pass the infection from the infected eye to the other eye. And you can see mucoid discharge over here. Then you dilate the punctum. You see how I'm stretching the eyelid and the probe is going parallel to the lid margin. And then you turn the probe towards the medial end of the brow. The direction is downwards, posteriorly and laterally. You will feel a give way and you will then feel the floor of the nose. And you can also put another instrument in from the nose and feel a metal on metal contact that tells you that the probe is down in the meatus. After that, you intubate if you have to. Now here I am showing you the Lacricat which used to be available earlier. This is a very old video. And then this one you can retrieve it through the nose very easily without an endoscope. But if you're going to use the Precon tube, then you need an endoscope. Now this is the QR code of this video. You can also see it on YouTube. Okay, so this is how you retrieve it from the nose. And then you go in from the other side of the punctum, also, other punctum, and then do the same procedure and retrieve it from the nostril. Once you have both down here, you just place 2 knots so that you can cut the tube here and pull it out through the punctum also. If you put many knots, then when you're pulling it out through the punctum, you can damage the punctum. So don't put too many knots. Okay, and this is how you need to tie the tube. You have to pull the tube so that the knot retracts in the nostril. When you're pulling, there should not be too much pressure at the medial canthus. So this is how I do it. I tell somebody to hold the tube at the medial canthus and then cut it down so that it's not pulling the punctum over there and causing a slit punctum. Okay, so now probing and syringing, good success rate if it is done within 2 years, and the success rate reduces as you do it later in life. And sometimes when you have to retrieve the tube, I told you, you can't see the posterior, the lower end of the NLD because it's posteriorly located. You need to infracture the turbinate, and that also opens up the lower end of the NLD. It helps in achieving patency of probing also, but it causes a lot of bleeding. You need to be very, very well versed with your endoscopy technique and also in retrieving of the tube. Now, failed probing is very common many a times because of anatomical variations. It's a blind procedure, and sometimes you can have false passages. So second thing is the silicone stent intubation, which I've showed you now. And you can use even these tubes or any tube that you're comfortable with, but keep it only for 4 weeks. If you're keeping it for very long, what happens is that there will be a slit punctum, there will be granulation tissue. There are a lot of issues with the tube itself. The tube can get dislocated. Sometimes it can rub against the ocular surface and cause irritation. So we don't want all that. Keep the tube only for 4 weeks. It's not going to help you more than 4 weeks. And then the gold standard for NLD is DCR. I'm not going through the steps of DCR, but you know that the passage is created between the sac and the middle meatus in DCR. Now, the commonest techniques are external endoscopy. There are other techniques like endonasal, which we are not discussing today. But both the techniques have equal success rate. If you see, if a good person who knows endo-DCR well, the success rate is almost equal. This is the QR code for the step-by-step of DCR if you want to see. And endoscopy has the advantage that you can also treat the nasal pathology. Like if they have a bony spur, if they have a septal deviation, then you can do a septoplasty at the same time. Patient is very happy, there is no scar. And it is much faster. If you ask me, endo-DCR is much faster than external. Now, failed DCR, I will just go through the commonest cause. I have seen many a times you do a DCR, patient comes back with discharge. Patient comes back with Rho plus positive. Now that happens if your ostium is like this, much higher. Okay, so the lower part of the sac is going to collect the secretions and that gives you a positive Rho plus. You have not opened the sac vertically down till the NLD. Okay, that is called the sump syndrome. And that you need to repeat the DCR. You need to open the sac completely till inferior end and only then it will function nicely. So sump syndrome is a common cause, and then other causes of failure like granulation tissue or fibrosis of the ostium is always there. Now, CDCR is not a common procedure. Whenever you have canalicular block or you have proximal canalicular system problems, CDCR was advised, but it's very difficult to maintain the Lester-Jones tube. It is virtually impossible. A patient sneezes and the tube falls out. A lot of fixation techniques have been devised, but I don't find much success rate in most of the hands. The other procedure is balloon dacroplasty, which is also not very commonly done. This was one of the book chapters that I had written in 2008, and that describes the procedure of balloon dacroplasty. We used to do a lot of these, but we find that the stenosis recurs after some time, and the indications are very few. Indications are when a child has a failed probing and a failed intubation, then before doing a DCR, you would do this. But I would say that again, trying something expensive like this and again it failing and then going in for DCR is something that many parents won't agree with. So what is done is, this is a balloon, okay? This is a 2 millimeter, 3 millimeter balloons are available for adults, 3 millimeter, and for children, 2 millimeter balloons. What we do is we go in like a probe only with a deflated balloon, and then we go to the lower end of the NLD and then inflate the balloon. Okay, to 8 atmosphere. We keep it for 90 seconds, deflate it, again inflate it for 60 seconds, again deflate it. Then you pull it up and you come to the junction of the sac and the NLD. Again, you inflate, deflate 2 times. That's all. And then you leave it, you don't intubate. So this is a very tricky thing because at that time it dilates, but it can restenose later. And so it is not very commonly done. I'm just going to show you so that you know how it is done. So this is the balloon. So first you do a probing, make sure that the probing is seen by an endoscope so that you know that the passage is correct. It's not a false passage. Now this is a deflated balloon that is going. It has 2 markings here. You go up to the mark which is 15 millimeter, that is lower end of the NLD, this first mark up. Then you take an endoscope and then you inflate the balloon. Once the balloon is inflated to 8 atmosphere, this is how you have a gauge here. You can see the balloon beautifully. Can you see it here? You can see the balloon moving there. And once you see that balloon and then you deflate it and come up and re-inflate it 2 times. Okay. So this is roughly the balloon DCP. Coming to special situations, which is the last part of my talk, in trauma and oncology, malignancy related blocks, because these masses block and press on the sac from externally. And these need treatment separately. Like this gentleman who had come to me many years back, he came for DCR. Now, if you just look at him, you will just go ahead and do a DCR. But on table, I found a mass there, and you can see the whole nasolacrimal duct is dilated. So this mass is going all the way down into the NLD. Okay, so I just took a biopsy and then came out, and it came out to be a lymphoma. When I go back now, after some years of experience, I see that I missed a very important sign here, which is telecanthus. Whenever you see a telecanthus, usually dacrocystitis or a mucocele will not cause a telecanthus. You can see the increased distance here. When you see that, you must do a CT scan before surgery. Okay. Now, trauma. Trauma is another very challenging situation. In trauma, what happens is you have eyelid scarring. So that affects the lacrimal pump. You can have canalicular blocks. You can also have the increased tendency of scarring. So you need a larger ostium in these patients. And also sometimes plates and screws will be there. The sac may be fibrosed and displaced. And also intranasal factors are there because of trauma itself. Okay. So all these patients, pre-op nasal endoscopy is a must. Do a CT-DCG in all these patients and then plan the ostium. Like in this patient, I have done the ostium in between the two plates. So you can do all this planning if you have a CT-DCG. Make larger skin incisions, make larger ostium, preserve the orbicularis as much as possible. Use mitomycin for all patients. And for DCRs, I use 0.2 milligram per ml for 3 minutes. And I intubate all patients and keep it for 4 weeks. Now, when you have double punctum, as I told you, rule out NLD block. When you have punctal stenosis, don't do snip procedures. Try to just dilate the punctum and do a mini monoca. Earlier, we were comparing the various methods of snip procedures with monoca, but now we all agree that we need to preserve the integrity of the punctum and the canaliculus. Now, this is the mini trephination, which is very successful if it is a distal canalicular block and common canalicular block. So what you do is you do a punctal dilatation, put in a probe, mark where the block is. When you see the block is more than 8 millimeter away from the punctum, you do a syringing. You see this is a common canalicular block in this patient. So this is the mini trephine, a sisler trephine, which has the stillet and you have the trephine. So first go in with the stillet. When you encounter the block, withdraw the stillet and push in the trephine, which is going to cut the block. And then you do a syringing. If the syringing is patent, you do a mini monoca intubation. This many people have not seen. That's why I'm showing these videos instead of showing a regular DCR video. And of course, Botox is a very good option. Whenever you have very difficult proximal canalicular blocks, my preferred choice is Botox. You just give a 0.1 ml in the lacrimal gland and it works for 3 to 6 months. It affects only the reflex secretion and it does not affect the basal secretion. Now, this is a nice, this is one patient that I wanted to show you. He is young man, road traffic accident, bilateral NLT blocks. He has very bad fracture. So we do the DCR along with the fracture repair. That's the best thing to do. That is, you do the bony reconstruction along with the DCR like we have done for him. You can see that his enophthalmos is corrected because we have corrected the bony reconstruction. And also you can see the two tubes on the either side of the DCR. And then we have done the soft tissue reconstruction and you can see that his lower lid is improved because of the DFG. Another patient like that, trauma again, he has very severe NLD block. You can see I have put a plate here for the bone as well as the DCR in the same sitting. Okay, now another very bad trauma patient, you can see how much the sac is enlarged and again a DCR in the same sitting. Now this was a very, now also when you are looking at the CT-DCG, you look at the cribiform plate. That is important. In this trauma patient, you can see that this is the crista galli, this is the cribiform. There is a fracture of the cribiform. So when you're going to do a DCR, you have chances of having a CSF leak. So in coronal sections, you look at the position of the cribiform plate. Also, you can see an Agarwals there. And if you see a very anteriorly placed ethmoidal cell, that will help you to plan the DCR. Now, this is another patient, telecanthus. As I told you, do a CT scan. You can see a big ethmoid mucocele. He only needs to do a FES and he'll be fine. Another patient, telecanthus, it's a mucocele. It's not a lacrimal mucocele. Now, this is a 10-year-old boy who came again for DCR. You can see the huge sac going into the NLD. This is the nasolacrimal duct. The duct itself is enlarged. So this, he had a diverticulum along with a sac. So all these findings you can see on the CT scan. This is the last patient. You can see this enlarged swelling at the middle, at the punctal area. I thought it was a malignancy, but when I went in, she had a huge calculus. You can see the huge calculus. So I had to do a snip procedure for her because with the curate it wouldn't come. And you can see the large cavity that it had created. And this was a surprise on table. To summarize, we have discussed the causes, the important factors in history taking, some of the examination techniques, punctal and canalicular disorders, inflammatory, that is ICID, and infectious, that is canaliculitis, and also special situations like trauma and malignancy. Thank you.
Thank you, Dr. Preeti. That was very, very in-depth and lucid, and I'm sure it was very, very useful for the postgraduates, especially.
Thank you.
You've already covered most of my questions at least, but I'll still ask a couple of questions, very basics. Personally, what is your preference now, endoscopic versus external, in regular cases without any, like where you are not expecting any complexities?
Yeah, regular cases, older people, I would do external. But younger patients, definitely the scar is quite disgusting and I would prefer an endoscopy. Like if I have to
Okay,
undergo, I will not go for an external.
all right. Okay, and now a tricky one. What do you and how do you deal with patients and manage patients with functional epiphora post anatomically patent DCR?
So most of the time, as I'm telling you, there will be some other secondary cause. Most of the time, blepharitis, membranitis will be associated because after any surgery, they don't clean the eye at all. That you need to treat firstly. And in spite of everything, if nothing works, then Botox is the last
Okay,
cure for any functional problems.
it works well.
It works well.
Anything special that you do for patients with post-facial palsy epiphora or gustatory epiphora?
Post gustatory,
Facial palsy, yeah,
facial, yeah.
aberrant
Crocodile
regeneration.
tear, yeah.
Yes,
Again, Botox.
again
Because
Botox,
yeah,
right?
because it's the reflex tearing and it is because of aberrant innervation. So
Yes,
you need to treat it only with Botox. Now there are new experiments where they are trying to debulk the lacrimal gland. They cut off half of the lacrimal gland to reduce the secretion and all that, but it's still not
yes.
clinically acceptable. They are still in the experimental stage. There is like a lot of research on, whenever there is a block in the drainage system, there is a neuro, regulatory feedback wherein the secretion also reduces and the patient many a times doesn't have epiphora. So all these are still in the experimental phase and they are studying this neuroregulatory reflex also. How is
Somebody is
Botox
asking how
given?
is Botox given and the dosage.
So the dilution is the regular dilution that we use for aesthetics, that is 2.5 units in zero point 0.1 ml. You ask the patient to look down and out, okay? So I mean down and in, so that you are seeing the palpebral lobe of the lacrimal gland. You inject zero point 0.1 ml only. If you inject too much, then it's going to go into the lateral horn of the levator muscle and the patient gets ptosis. Ptosis is common after this lacrimal gland injection, and therefore you must be very careful about that. I know a lot of surgeons who super dilute it. That means you have 2.5 units in 0.05 ml. So that you're
Okay.
giving a little smaller quantity, not even 0.1 ml. You're giving 0.05 ml. Okay. So you can
All
do
right.
that also. Dilute it in such a way that you have increased concentration. You're going to give the same units, but you're going to give lesser volume, which is
Lesser volume.
a foolproof way of giving and not having ptosis. Because
Avoiding ptosis.
I myself have had 2 cases with ptosis so far when I've
All
done
right.
so many thousands. It is a common problem, and I found that as a good solution. But if you dilute and keep it, then you have to again dilute it for some other patient for aesthetics.
Ma'am, I had, yeah, one more question because you were describing like you avoid punctoplasty completely now. I still end up doing punctoplasty in at least canaliculitis patients personally. You were saying that obviously, usually the NLDO problem is not coexisting and syringing will be patent. So personally, I do syringing from the opposite punctum just to confirm it before taking them up for any procedure. Is it also possible, or do you do it from the same punctum which is involved?
No, what I meant
In
to say is that even if there is an inflammation of the canaliculus
yes,
does not get blocked.
correct,
It's only the wall which gets inflamed. So I usually irrigate them with antibiotic. That antibiotic irrigation is possible because there is no block. And the antibiotic does
correct.
not stay there, but I find that it works very well. We have done a study on so many patients in that paper, have also shown that irrigation helps. What I do is call the patient every alternate day if they are locally available and milk it out every alternate day
Yes,
and syringe with the concentrated antibiotic. That way, canaliculitis usually
response.
99% respond. I don't need to do a cut down because if you're going to do a cut down, that function of the punctum is gone. It's never going to have the capillary action or the suction. Though it is the whole system
Even a single
dilated.
snip?
No, it will not, because that snip is going to scar. Okay, so that scarring is going to stenose the punctum. So now worldwide, if you listen to any of the researchers who have been researching on this system, we want to preserve that punctum and the
Preserve the punctum as much as possible.
and it's so
Okay.
much dilated, you can put in that curate also and curate it. You don't need to cut to remove the secretion. Milking in
Usually
every
it is
different
inflamed
direction.
and yes,
Yeah, the
yes.
milking has to be learnt actually, because we tend to go in towards the common canaliculus. You need to come more
Out.
laterally,
Yes,
because sometimes the diverticuli are there and you need
yes.
to squeeze out everything. You saw how much I'm trying. Every time some little secretion comes, I'm pressing in different areas. So it takes time to milk it out completely.
Patience, yes. And during curettage, there's no chance of pushing the granules further
Usually, no,
distally.
it's a huge cavity. So usually you're
Hmm.
able to scoop it out.
Okay, somebody, Dr. Preeti has asked, can you please let us know guidelines for pre-op evaluation for Epiphora prior to cataract surgery? This is of use to.
Yes, so this is a big controversy, and most of us now have, and all the studies have proven that syringing is not needed preoperatively if your Rho plus is negative. You need to do a Rho plus very well in most of the patients, and if the patient is asymptomatic, does not have any sticky discharge, no discharge, no matting of the eyelashes, and your Rho plus is negative, you can safely take them up for surgery. If there is a canalicular block on syringing, suppose you have a doubt, you have done a syringing, if there's a canalicular block, take them up for surgery. That conjunctival swab and all does not help, because you have normal commensals in the conjunctiva, and those swabs will keep on coming positive and you keep on postponing the cataract surgery. Does not help, because there is no collection of secretions or water anywhere. There is no collection of tears anywhere for it to get infected. But of course, if there
Even
is
in one-eyed patients?
even in one-eyed is treated same as normal patient. Even if the patient has both eyes, we have to use the same precautions. So there is no such thing as one-eyed. You have to be extra careful. Anything we are
With
extra
swab,
careful
with
even for
respect to
patients with
swab.
both eyes.
Yes,
Yeah,
absolutely.
yeah,
I agree.
yeah.
Okay. And so basically, the take-home message would be first of all to learn how to do Roplas properly for every single ophthalmologist, whether or not they're an oculoplasty person. Then next question is for acute dacryocystitis, how many days later syringing and surgery?
Yes, so acute dacryocystitis, we don't do syringing because it's painful for the
Yes.
patient. So you wait for at least a week or 10 days. When the inflammation, acute pain subsides, patient does not have tenderness, you can do a syringing. But surgery after a month. Because if you're doing surgery in an acute, if there is acute inflammation, you'll have more of bleeding. The tissues are more
Yes.
friable. You can even create, even intubation sometimes is difficult because the mucosa is so inflamed. You will have a false passage when you go through a probe.
Yes.
But you can do endoscopy if it is
And
acute
many patients are
dacryocystitis.
on blood thinners as well these
Yes.
days. Personally, if Roplas is positive in the clinic, especially if it's mucoid or purulent, then I avoid syringing because that itself can lead to an acute dacryocystitis episode.
Yeah.
We
You
don't
can just
require.
press out the secretion and you know that it is then straight
Yes,
away a DCR.
directly we can. Yes. Next question again by Dr. Preeti. How should we handle atonic sac and epiphora?
So
Counseling.
atonic sac is not able to pump the secretion down into the NLD by itself. Okay. There is no way that you can improve that pump mechanism and the tone of the sac. So DCR is what we do so that the path of least resistance, the tears will flow. Atonic sac also, we do a DCR.
Ma'am, thank you so much because you clarified so many basics as well, apart from going in depth into the anatomy, from anatomy until, definition surgeries. So thank you. Really appreciate.
Thank you. Enjoyed the evening.